Welcome everyone to the live case at lecture 7, which is entitled TAVR Basilica. We are very excited to have a live transmission from Israel, and I think this is one of the few times we ever will see a Basilica case live. So welcome everyone. I'd just like to introduce our discussant this evening or morning, depends on where you are. We have Dr. Hayashida, Dr. Cole, Dr. Park, Dr. Tada, and Dr. Waxman. So welcome everyone to this exciting session. And obviously more important to have our live case operator, Danny DeVere at Shatzir Medical Center from Israel. And welcome, Danny. So I will turn it over to you to introduce your operators, your colleagues from Israel. Thank you.
Okay. Good morning, everybody. It's a great morning here in Jerusalem, Israel. We are very happy to introduce a very interesting case. Let me introduce the team. I'm Danny DeVere. I'm the head of the cath lab here in Shaarei Tzedek. Moni Shuvi, Ami Harari, and we have with us in anesthesia Dr. Dimitri Greenman and Dr. David Rosenman here in the echo, and we have with us Yossi, Karmit, and Elias, and Muhammad in the team. And we have a very interesting case to show you, so please, Ami, let's start with the slides.
Okay. Okay, so our patient is an 81-year-old lady who had a surgical valve replacement eight years ago with the Magna Ease 21 valve. She also had a cabbage with a vein graft to the diagonal. Other comorbidities, she has HFpEF, severe MAC, pulmonary hypertension. Next slide, please.
Next slide, Hashem. Next slide.
Okay, other than ischemic heart disease, she is hypertensive, dyslipidemic. She has Sjögren and spondylosis. Her renal function are quite good, and she developed F4 dyspnea recently, and she is in functional class 3. Next slide. On the echocardiography, she has a good LV function, a hypertrophic ventricle, and she has a degenerated aortic valve with mixed failure, both aortic stenosis and very severe and moderate to severe aortic regurgitation. The mean gradient is 26 millimeter mercury. She has a MAC and with a mild to moderate mitral stenosis and mild mitral regurgitation and significant pulmonary hypertension. On the ECGs, she has complete right band branch block. She's treated with clopidogrel, diuretics, and ramipril. Next slide. Or you can see her echo here, the hypertrophic ventricle with preserved or good LV function, and the AI, which has both intravalvular and paravalvular components. Next slide. You can see the gradient here, with a mean gradient of 26 millimeter mercury. Next slide. And here the aortogram, you can see that there is a regurgitant jet that reaches the apex, very significant AR, both intravalvular and paravalvular. Next slide. This is the 3D rendering of the CT. You can see that she has a bovine arch, which is important when you do a sentinel or cerebral protection. The bovine arch meaning that she has a common origin of both the left carotis and the innominate. Next slide. The aorta itself is quite tortuous, which might make the procedure more difficult. Next slide. And the periphery is quite good. You can see that the arteries are within a good caliber and without significant calcification. Next slide.
Okay, thank you, Ami. So one of the main challenges in this case, it's an interesting case, we have many challenges. One of them is the risk for coronary obstruction. You can see the height of both coronaries. Clearly, both are very low. The left main is around 3 millimeter high, the right is 6 millimeter in height, and you can see from the picture that the surgical valve is tilted towards the left main. So the risk for the right obstruction is low, the risk for the left main is elevated because of inflow, because of sinus sequestration. Let's see the next slide. Obviously, the sinuses are not very small. The VTC, the virtual THV to coronary distance, is above 4 millimeter, but the inflow to the left main is below 3 millimeter, which is considered a high risk for coronary obstruction. Next slide. And with regard to the definitions, what are the cases at risk for coronary obstruction? This is the classification that is usually considered, type 1, type 2, type 3. Maybe we'll not dive into that. Next slide. This is a type 3C case at risk for coronary obstruction, in which the inflow to the left cusp is jeopardized when we do valve-in-valve. Next slide. So the procedure planning would be general anesthesia. We aim to use a cerebral protection device, but she has such a severe tortuosity in her right brachioinominate system that it was not able to deliver even the sentinel there. And we will avoid coronary obstruction with left cusp basilica. We will try to aim to avoid prosthetic patient mismatch with bioprosthetic valve ring fracture, BVF, which has some risks in this particular case, and we will aim to implant a supraannular THV device, which means here Evolute Pro. There are two other considerations that we can observe in the TE here with Dr. Rosenman. One is that the patient has some degree of paravalvular leakage. It's not only stenosis, and it's not only intravalvular regurgitation. She has paravalvular regurgitation, and it will be important to see what happens with that when we implant the Evolute Pro a bit deeper than conventionally. And the second, she has a bit of LVOT gradient, and not only in the plane of the surgical valve. Next slide. Just to describe quickly about Basilica. Basilica, in collaboration with the NIH, with Robert Lederman and Jaffer Khan, and many other friends, we aim to lacerate the left cusp. We will need to traverse the left cusp with an electrified wire, and later on we will slice that cusp with the same electrified wire. We will talk about, we have enough time to really go step by step during this procedure. And by lacerating that cusp, we hope to reduce the risk for coronary obstruction. Next slide. When we talk about Basilica, there is some terminology that we need to understand. When we do TAVI, usually we do not ask about characteristics of a particular leaflet, but here, since we need to slice a leaflet, we need to describe that leaflet in space. So the left cusp has a side view and a front view. The side view is the view in which we see it from its side, and we want to aim towards the leaflet, and the front view is the view in which we see the leaflet from side to side, and we want to aim to the center of that leaflet. Next slide, please. And with regard to the Basilica angulations, here are examples of her, from her diagnostic evaluation of the left side and the left view and the front view in front of you. Next slide. Maybe you can continue, Ami, describe the surgical valve.
Okay, so this is a Magna EASE 21 valve. It has a stent diameter of 20, but the leaflets are within, so the true diameter is 19. The area of the valve is 1.7 centimeters square. Next slide. You can see here how an Evolute valve can be implanted in such on the bench in such a valve. The problem that the gradients can be high, so in order to avoid it, a valve fracture can be done. Next slide, please. And you can see here on the table the pressures that are described on the bench that can cause a valve fracture. And if the patient will be stable after the laceration, we plan to inflate the valve and fracture it. Next slide. Okay. You want to?
Well, we described already our plan for the case, and maybe we will go directly to see the echo images. Please, David.
So Daniel, quick question. Are you planning to pre-fracture or are you going to fracture after you're put in the evolute?
It's a great question. Actually, now we have three options of pre-basilica fracture, fracture between the basilica and the valve-in-valve, or fracture after the valve-in-valve. One of the main concerns in this particular case is the fact that she is at risk for annular injury. Even though usually in valve-in-valves we are not feel that TAVI is at risk for annular injury, here she has a very small LVOT with calcification. Look at her mitral valve. Here, I'll show you live image of that. You can look at the fluoro. This is something dramatic. This is you do not want to inflate something big in that LVOT. And she's almost 90 and very frail lady. She's really at risk for having annular injury. We will aim to do that if she will be stable between the basilica and the valve-in-valve. If after the basilica she's not stable, we are rushing in with the valve, hope for the best. We aim to use a 26 Evolute Pro in this particular case. It's a lot of oversizing. It could be difficult to position it well. We aim to position it a bit lower than usual. If we need to rush with the valve in a deeper position a bit, then we may do the valve-in-valve, the surgical valve fracture after the valve-in-valve. We'll take it live. There are many considerations. Actually, we only started the case now, so we have enough time. We can go step by step and think together what is the best thing. So please, if you have more questions, we can answer, or maybe we look at the echo.
Maybe also we can describe what we did on already.
Please go ahead.
Okay, so David, maybe you'll take us through the echo images.
We are on low esophagus here. You can see the aortic valve from long axis view. You see the opening of the aorta. You can see the opening of the aortic valve. You can see also, we'll see the Doppler. See this level. Okay. There is quite significant aortic incompetence. It's a little bit difficult to see it on this view because of reverberation, but there is no doubt that she has quite significant aortic incompetence. We can see also, you can see the mitral valve with mitral annulus calcification. Okay, you see the mitral valve. She has mild mitral incompetence. And she has a mean gradient of 5 on the mitral valve. She has also some significant tricuspid incompetence that we don't see quite well here. No. The left ventricular contraction is preserved, almost normal. We cannot see it here, but we see it very well on the transthoracic echo. Okay.
Okay. Perfect. Can you go through short axis for a second? One question that we want to understand before we go too far, if you want to go to my fluoro image again. So I have a catheter now, a multi-purpose through the surgical valve, and I have a snare, a 20 millimeter snare matched for the perimeter of the LVOT, and I have a V18 wire waiting just to anchor me that I'll be able to go back to the LV if needed. The first question is, David, am I through the orifice of the valve or am I paravalvular?
Yes. Okay.
How certain you are that you would need to fracture it at all?
Okay, she is a little bit more
primarily regurgitation, not stenosis.
Okay. Back to the aortic valve on short axis, we can see the quite significant calcification of the left end of the right coronary cusp. You can see it. And we can see also the aortic incompetence. Not very severe here.
זה טוב לחבר כאן. לא את זה, את הלחץ השני. אוקיי.
שטיפה שם.
Okay, so
Some mild to moderate mitral incompetence at the moment.
okay.
Danny, do you
Thank
hear
you.
me?
Yes, we hear you well, please.
Yeah. So one question, if you want to go again, because this is one of among the first demonstration, at least in this course for Basilica, step by step. The first that you did was you put the snare in and then the V18 wire. I mean, what was the order of placing those wires?
Yes, it's a great question. So here is a surgical valve that we aim to treat in this particular case. I'll just free it a bit. I'm in REO. I crossed the surgical valve with an AL, and actually it was not easy to cross it. Obviously there is a component of stenosis. And then after I crossed it with an AL1, I switched to multi-purpose guide, and through the multi-purpose guide I put a V18, which is a small wire that you see here, and in parallel to the V18 I put the snare, the gooseneck snare, 20 millimeter. Now we can a bit go through the anatomy of the surgical valve. Maybe David, you can pull the probe a bit for us, and we can look at the fluoro images. So as we said, we describe surgical valve leaflet positions in side view and in front view. The side view would be like, we have 3 posts for that surgical valve, and between each 2 posts there is a leaflet. Now I align 2 of these posts together, as you can see on the right side of the screen, and the left cusp is just between them. And our aim is to lacerate that leaflet that sits between these 2 posts. So my next step would be to bring a guide towards to be behind the left cusp. She has a lot of tortuosity, as you can see, which is quite interesting. We thought at some point that she may have a right aortic arch, but it's just severe tortuosity.
A long sheath can help you with this.
Yes, absolutely.
The
Interesting.
other question
Please.
before is the patient had CABG with a graft to the diagonal. So how much of this diagonal is filling the left system? I mean, I understand you're concerned about the left system, but you have a bypass grafted to that area.
Right. It's something that this one did not feel the left system a lot and may not feel it too much. And in previous cases, I used to inflate that graft with the left main with a balloon, and to inject through the graft and to see how much of that graft feel while there is an obstruction, to simulate an obstruction to the left system. But here I thought that it's the vein graft to the diagonal, that one could not feel the full left system. So what we have now is an AL guide sitting in the left cusp behind that leaflet that we want to lacerate. Our
This
aim
is
now,
an AL1 or AL2?
it's a AL27 French. The multi-purpose is conventional. As you can understand, I'm really oriented far from the leaflet. We need to have a catheter that will bring us towards the leaflet, and for that we will use, there are dedicated catheters for that. In this particular case, we will use a combination, a telescoping of systems. So if you can come to the table here behind me. Where is this one? Or maybe we will bring it to the main table. Just a second.
I think it's better.
For the audience, it's always challenging to bring the guiding catheter, which was not designed necessarily to direct it. So you point exactly to the leaflet and not going to go behind the valve, which is sometimes challenging. It takes some time.
So what we have here on the table, maybe we can focus here. we have a long JR diagnostic catheter. Then the aim for us is to come to the end of the AL and to point towards the left cusp. At the back of that catheter, we have a microcatheter that is, I think is the best for this type of situations, which is called piggyback. We can describe it later on when we get to the step that we use it. And inside the piggyback, we have an Estato XS20 wire that we will use to pierce the leaflet and later on to lacerate. So this is the combination that we have. We can go back to see the, to see the screen. So we have AL 27 French with a JR diagnostic through it. There is a piggyback microcatheter through it, and through the piggyback we have an Estato wire. So the next step for
like
me.
a mother and child.
What do you say?
No, it's like a mother and child.
Yes,
system
exactly.
that builds
Yes,
up.
yes. The next step is
And
to
maybe
bring. Please.
one more question about the classification of that leaflet, because often this is an AR more than AS, but if you have a heavy catheter, do you have any tricks to go through a very calcified leaflet?
The most calcified leaflets we often go through would be the natives, or when we do it for bicuspid sometimes, to tricuspidize a valve. These are the most, something to cover? These are the most challenging ones to go through, and usually we aim to use more electricity, and actually the positioning is the most important step to make sure that we can go through the leaflet. The actual positioning behind the leaflet is the most important step in this procedure. So now we start the challenge of the Basilica, which means stand behind the leaflet and to be correctly positioning towards that leaflet, attacking the leaflet, as we say. And here you can see me bring the combination of the diagnostic catheter through the AL. We bring it to the end of the AL, and then I unsheath the AL back. You see that it really wants to go to the correct position naturally, which is makes me really happy now. Okay, so what we can see now, I'll see that. We see that my combination, the dot that you see at the end of the catheter is the end of the piggyback microcatheter.
It's the marker.
This is my marker exactly. Maybe I'll bring the Estato wire a bit closer.
זה דיאטרמיה פה?
Yeah.
And also, if you can share with us the energy that you are using.
The what?
electrified.
איפה הדיאטרמיה?
The energy.
Diathermia.
The energy?
Yeah.
Yeah, we
To
didn't
electrify
reach
the-
that point yet, but that's a great time to do it. So, the end of the Estato wire, we want to electrify that wire, will need to be scraped. It's quite amazing. Can I have a scalpel, please? It's amazing how much material that we have on these catheters, and we need the pencil of the diathermia system. So if you can
diathermia.
focus on my, can I have a white
Thinking about the coating.
pad?
דיאטרמיה.
If you want to focus on my pad here. So we'll scrape the back of this wire. We'll do it by pulling the wire while I'm holding the scalpel on the wire. You can see how much material I got over it. It's quite amazing. Clean it quite well.
קח את הזמן.
Danny, the reason why doing this job is to make some increase of electrical, the electrical conduction, right?
Correct.
Okay, so you can see it's becoming silver here, or gray in this area, and over here it's covered with Teflon. It's green, so this is a good area. We can throw these pads away. And now we have the pencil of the diathermia.
It will come in a second.
Will come in a second, okay. So until the pencil will arrive, we need to see that we're good in the other position as well. So, perfect, thank you. You can connect there. So in the side view, we were happy. Let's see if we're happy in the front view, which for the left cusp, it means RAO caudal. And obviously, as you can see, I'm not oriented. Now the left cusp is between the right side of the screen and the left side of the screen. And obviously, I'm oriented completely off, which means, in this case, I need to do counterclocking gently. It's all about gentle movements in these procedures.
This is very important because otherwise you have to go check all the time both views.
Now I'm happy in the front view, and actually you see that I'm jumping with the leaflet. This is a nice morphology of being on the leaflet. That's a nice front view positioning. I'm going back to the left, the side view of the left cusp. It could be nice to do these cases sometimes in a
biplane.
In a biplane, for sure. For some reason, I never got interested in that, but maybe one day. So I'm on the leaflet. I'm a bit medial in the positioning, but actually I really like it. Surely I'm behind the leaflet. Maybe this is a good time to go back to the echo and ask David, I have one catheter through the orifice of the valve. I should have another catheter sitting on the left cusp. Do you see us there?
Let's have a short axis view.
So, Danny, do you ever give contrast to that?
We try to minimize contrast here in that old lady. We sometimes can inject through the AL to understand better.
Yeah.
It's not so clear all the time.
But the contrast won't help much. I think.
Yes, for sure.
Yeah. And you
let's connect. Let's do it. Let's connect here with the contrast.
Okay.
We can see the wire crossing between the left and the.
There should be one catheter behind the left cusp. Do you see us?
Yes, we can see you behind the left cusp.
Do you see us in the middle,
between
of
the
leaflet?
Yes.
Okay, so we're happy. Let's connect. איפה מזרק הזרקון? רגע. הנה זה כאן, דקה. But we'll take your advice and we will do an injection there, a small injection directly towards the left cusp. One of the advantages of doing it with the 7 French or 8 French is our ability to inject at this point. It doesn't aspirate well, so maybe we'll skip that.
Yeah.
It's probably against the wall.
It's against, you know what?
The cusp.
Against the leaflet. It's actually, we're very happy with the position. So, like we're in the left cusp, it's moving with it, so we're happy. Let's see the...
Give it a try, there's nothing to lose. If it's not going to pass, it's going to be...
Exactly, yes. So, we can focus here on the table again. So we're connected to the back of the stator wire with the pencil of the diathermia. We are set, let's make sure that we are set for, let's do 50 watts, pure cut.
It was preset.
It's set already, okay, perfect. And you do pure cut, which means the yellow button here. We'll make sure that the stator wire is free and it's not entangled with anything and it's completely dry. I'll come closer a bit to the leaflet.
Okay. See the fluoroscopy when you're doing it.
Yeah. And when we're ready, we'll cine, and then I'll ask on. When I go on, you press on the yellow. When I ask off, you off. Okay, ready? Just a second. I want to see the pressure. Why don't we have pressure on the screens at all? How come we do not have pressure here? אנחנו איבדנו את הלחצים, חבר'ה, דרך אגב. את הלחץ השני.
לחץ. הלחץ, מוחמד?
Here I connected to a different place.
אוקיי.
Okay, we're ready?
כן, תגיד לי מתי.
Okay. On. Off. Okay. Clearly, we went in. What we can do now, we can push a bit just to see where we go. It feels like we're in the LV. Left cuspid traversal sometimes go through the curtain to the LA. So we do our echocardiographic just to understand the position. Here we have such a severe MAC, we'll understand easily where is the mitral valve.
לחץ דם קצת. כמה לחץ דם שלך? כמה שלך? 90 זה בסדר. בסדר גמור.
Okay. It seems that we are in the LV with the wire, which is a good sign for us. Now we're gonna hope to see that we are in the snare. It's not clear. We are in the snare. We're very happy. I'll take out the anchoring wire that was inside the multipurpose. It doesn't have any role anymore.
Pigtail. Pigtail.
Also D18.
The next thing would be to invaginate the stator wire inside the multipurpose.
Danny, how do you know how far you actually started the crossing the leaflet? Was it near the base, or it seems like you are not at all the way down, right? So how far down do you actually aim to start the laceration?
How much below the valve I want to snare? You're asking.
Yeah.
No,
No, I'm sorry. Where did your stator wire cross puncture the leaflet?
Yeah, you're asking whether to just keep the stator high. I can keep it high. I just wanted to make sure that I'm going towards the apex of the LV. Now I snare the wire and I bring it
Maximum output. Asynchronous.
slightly above. Now I'm happy. I have
תחבר.
a loop through the valve. I'll free a bit my catheters from the valve just to let it breathe. Sometimes it can create a lot of more regurgitation during that step.
לא, לא.
Okay,
פשוט כל
now
הזמן.
we have the loop.
כל הזמן.
So from now, in general, after doing really a couple of hundreds of Basilica cases, the challenges of the Basilica procedure are actually behind us. The traversal went first attempt and the snaring was natural because it went through the snare. Now we are left with doing the laceration, which is a bit technical, and with the valve-in-valve and the challenges around it, which in this particular case could be more challenging than the actual Basilica. So we need to bring the wire in a way that it can lacerate the leaflet. And for that, we have several steps during the Basilica procedure. זה הלחץ דם.
לא, יש לו לחץ דם יותר גבוה שם.
70.
Okay. So maybe we aspirate here in 0. Just a second.
Okay. Can you, the pacer, put her on 85?
בסדר. Okay. Can you zero here, please?
Do you have anesthesia?
Sure,
monitor
FS?
for blood? Because sometimes it's easier to look at the anesthesia.
Okay.
תן לה טיפה תמיכה.
הוא מקבלת אדרנלין.
Okay. She's not very happy with the procedure until here, hemodynamics wise. Okay. I'll open the catheter. David, how much is LV EF? How does it look?
להשתלה.
Okay. The next step for us is to prepare the kinked wire in order to do the laceration of
If
the
you want to raise
leaflet.
blood pressure, you can pace her faster, and then that will raise the blood pressure.
True. Maybe we'll pace her 100.
טיפה נור.
It's a good, great
מקבל.
advice. בוא נקצב אותה
100.
100 בבקשה.
110.
עד 110 גם טוב. אני מחזיק את ה-AL ואנחנו מושכים את ה-JR על זה. אוקיי,
בסדר?
אוקיי. כן.
ככה.
נשאיר את השחור באותה נקודה ואת ה-JR. So the JR is being removed from the body. Maybe we look at the table again like we did before.
So just to explain everybody, you do have the AL1 still there, or AL2, sorry.
אני השחור
and
פה
you have
בחוץ.
somatic purpose, and then you have this there.
תוריד את זה ל-80. תוריד ל-80.
Let's go down to 80, please. Yeah. Okay. So we are removing we had a telescope of things in order to do the traversal, to go towards the leaflet. Now we are obliged to remove these covers. So first just a second.
יש לך רגע את זה עכשיו.
Actually, the piggyback went through the leaflet. You see that clearly. נמשוך עוד. דחוף את האסטטו.
Danny, did you create it already, the D?
No, we'll create it live. זה יוצא?
לא.
Just a second, here it comes, just a long way, okay. Now, it's not locked here, right? Okay, דחוף את זה בבקשה. Okay, let's remove the JR altogether. זה לא יוצא כל כך בקלות, רוצה להבין למה. שנייה אחת. פה, דבר ראשון בוא ננתק אותו מזה. We need to disconnect the wire from the pencil. Now we take the JR back. Okay. Okay, show me the back of this piggyback, yeah. So, we'll go back a bit here until I free the wire over here. שוך אותו טיפה אחורה. Pull it back a bit more. Okay, stop for a second. Okay, so now we reconnect to that wire over here. So we took out all the covers from the traversal system, which means the JR, and we pulled the piggyback a bit back. We freed the connection to the pencil. Now we reconnect to the pencil.
אז אתה מוכן?
Now is the time to prepare the valve for sure,
Valve?
yeah?
מוכן?
Okay.
מוכן.
אוקיי. אתה צריך...
Okay, we go back a bit
isolation.
here. Now we do, can I have a syringe here just to close the bleeding thing here?
Here you go.
Yeah, can you hold it here? Okay. So-
The valve ready just in case the patient has severe AR or need an emergency.
One of the important things why we like the piggyback is the fact, if you can focus on my hand here, that we are able to lock it over the wire. You can see it here. You can see the table? Okay.
Yes.
By pushing here that groove over here, I was able to make them one unit, the microcatheter and the wire, and it will stay locked until the end of the case. We do not push or pull it anymore. And now we focus on the other part of the wire over here. We want to create a transcatheter knife, which means it could be used for many other fields as well. So can I have a scalpel and a pad?
Here.
So I want to have all the electricity concentrate in the inner curve of a kinked wire here. So first I'm gonna remove again the cover from the wire in this area, just distal to the exit from the piggyback. After I did that, only in one part of the wire, I didn't do it fully, not circumferentially. I create a kink on that area. You can remove. Just a small kink in the beginning, you can put it in the back. Now I will improve that kink and make it more aggressive.
It's called the flying V.
Flying V, yes. Here you can see it. Now we have a denuded wire over here. Can we have the scalpel again, just to, it's like a blessing to the wire before it goes back to the body. Not sure why I do it, but usually I do it. I just scrape it here in the inner curve. Okay. Okay, it's ready to be inserted towards the leaflet now. We can take it back, and our ability to insert it towards the leaflet would be with pulling with a snare. So the first thing I will do, maybe we'll focus on the table again, is to deliver it through the TUI. Because there is a kink and I need to deliver it through the TUI. Just pull it from this place back. So now the kink is inside.
ACT יש לנו?
Now we'll push it in. Just a second. Now you need to pull the snare.
זה ואחר כך...
Now I'm working with Moni together. Moni, pull with the snare a bit more.
מעל 250.
Okay.
תן לו עוד
Okay, stop for a second. Now Moni is pulling with the snare and I'm pushing the kinked area. Let me see, where is my AL? Is too high. I bring the AL back towards the leaflet. Okay. Let me pull all of this guy back from the leaflet. Just a second. Okay. Just a second, let's pull this guy a bit more. Okay. Now you pull, I push gently. Pull. Let me push a bit more than you pull. Just a second.
It would be nice to do this all the
קדם את זה טיפה. קופץ למעלה.
Okay.
קצב אותה, מונים. כמה קיצור?
Okay, pull me more.
קצב 90, מקסימום אאוטפוט.
תסתכל עם ה...
Pull me more. Do you see the loop?
כן.
Okay, pull me a bit more. Okay, stop for a second. Let me push a bit more. Let me see a bit above. How far are we? You see here? It doesn't really... It's not really inserted. Let me see why. Okay, תמשוך.
מושך הרבה.
רגע, שנייה. תגיד.
one is pushing, the other one is pulling, and we will come into the...
תמשוך עוד.
עשינו נקב, עכשיו אנחנו לפני חיפה.
Here, we see the kink coming in the descending aorta. Do you see us there behind the TE probe? Now it's coming back. חכה לי שנייה.
חכה לך.
pull me a bit. כן, תתמכו בבקשה. pull me a bit more.
זהו, אני כבר בחוץ.
אז תתפוס אותו שלא יברח, כן? עצור שנייה, שים עליו, put a clamp on it before it runs away. Okay, so unfortunately she's not very stable, so we will need to be quicker here and will not do the BVF at this point.
Okay.
So, let's see the valve. We want to see that the valve is ready for us.
Can you check the pacemaker? I'm not sure if we are pacing good.
תוכל לדחוף את הקוצר אולי? יופי. מצוין. לא תעצור.
Okay, can we check the valve? And I need the AL1. You can take that to the back. Okay.
בסדר. L1.
Danny, right now you don't have any wire across the valve. When you put the valve, you need to
L1.
the valve.
Yeah, we are only checking it. We'll have a pigtail through the valve in a second. Let's see it. For sure, we will be fully prepared. The only thing is just, she is a bit with the hemodynamic instability. Let's have a look here that we are happy with the valve.
It looks good.
Okay, very good.
Okay.
Okay, let's have the wanted dilator here, and just a short wire, and a long wire. Where is just this one? Yeah. So I can say that in the beginning of the case, crossing the aortic valve was more challenging than I predicted. One of the challenges with Basilica is that we need to cross several times. Okay, take it out. Let's bring the pigtail, the AL on it.
Would you recommend to keep the V18 just so that you will have an access to the ventricle?
I had some thoughts about how utilizing that V18 in some way. The issue is that when you do the snaring, it interferes if you keep it.
So the snaring is smoother when the V18 is on.
Yeah. So that would be the second course of the valve, and for double Basilica we cross another time even. So surely there is room for dedicated tools to do Basilica, and Ron knows about several of these tools. Let's have a straight wire, please. We did 5 dedicated tool to do leaflet laceration called shortcut of picardia. Actually really successful cases is a compassionate use. There will be a study that will start soon in the US and Europe and Israel.
They're really going to be a game changer.
Yes, for sure.
You've done so far 4 cases or more than that?
What do you say?
Have you done 4 cases or more than that?
We did 5. I did 5, and there are several others waiting. There is a shortage of systems, and
the system is not ready.
So 2 days ago we did a conventional Basilica, and this one could have been a shortcut as well. Would have been interesting to show a shortcut live as well, also at some point.
That's what I meant about recrossing the valve.
Yes.
You had it once, you can put the pigtail, just be ready.
To keep 2 wires there during, but sometimes it interferes with the previous steps of the procedure.
You get it. You got it very smart.
Yeah. The AL2 could have been better here, but we'll see. The previous one that crossed was AL1.
Okay.
One of the things that we need to keep in mind, and I had it in several cases, that we have a hole in the leaflet, right? We can cross to the LV now actually in three different approaches. We can go through the orifice, and this is what I like. We can go through the PVL that that lady has, and we can go through the hole in the leaflet. So we will utilize the echo to understand where I went. Let's go to a different angle. Let's go to RAO caudal.
We have AL2 if you would like to switch.
שתיים שיהיה לנו.
There is an option always to pull the leaflet with the Basilica catheters. That also we used to do that in several cases, but we need to understand that by doing that, we may tear the leaflet early. So
It looks like you crossed the valve to where you need it.
yes, I'm creating the ectopy here, guys. So it's important to understand where we crossed. So let's go to different angle just to understand. It does look a bit like as if it's not in the hole in the leaflet, right?
No.
Because the leaflet is on the right side of the screen, right, where the dot is. And the AL is to the left of it, so we're happy.
Yeah.
Just to confirm, David, I have crossed now, and I just want to understand that I'm not through paravalvular leakage or something like that. I'll put a stiffer wire through it, and then we'll be able to move more freely there. And we can have a pigtail there as well. Maybe, Ami, you can suture both sheaths, the two arterial sheaths, you can suture them.
You can see the wire crossing the aortic valve. I think it's
Intra?
intra. I think it's intra.
Okay.
I think
We are
it's
not
a-
really in the apex. Just a second, Moni. Let me do RAO and we'll open the apex better.
When you take a
Good,
picture, it's going to be easier
I see explain.
Oh, we are at the apex. She's just very small.
small apex.
You can see the Mac that is really typical old lady Mac. Yeah.
Look at the
While we do it, Ami is suturing both arterial sheaths. It's important to suture them, or you can have someone hold them and then just push the wire a bit more. Okay, looks good. Let's have a pigtail. So obviously we could have stayed like that with a stiff wire in the LV. That wire is preparing us to do the quick TAVR after the laceration. The issue is that there would be a metal wire very near where we're going to electrify another wire. We do not want the LV to get some of the energy. And I had several cases in the early days that had the LV hematoma or a couple of pericardial effusions, not tamponades, but pericardial effusions that we never really understood why they happened. But obviously we need to be very careful with these electrifications, and especially when it's proximal to the vessels that go to the brain. So I brought back now the pigtail. Fortunately, it's completely free, sitting in the, not sure if it's free actually, let me see. Okay, it is free. Keep the pigtail over there. Okay, so now the pigtail will not be electrified because this is
the wire.
not something that can be electrified. Ami sutured both arterial sheaths. Now we are preparing for the next step, which means the laceration. And in order to do that, I'll bring both catheters closer to the area where the leaflet is. Just a second. We'll have several clamps. This one is good here. Another one is here, perfect. We close all two is strongly together.
Dextrose is here.
Dextrose is here. My fear is that the AL does not aspirate well, and I do not want to pull
Don't
it.
inject through it.
Yeah, so we will not inject through it. Can I have a syringe just to see if he does aspirate? In many of these cases, we inject dextrose live during the laceration period. Here, I think I will not do it because I do not get a backflow. Oh, it's very small backflow. We can inject through this one.
Purpose of the dextrose then?
The injection of dextrose can potentially improve the laceration. There are suggestions that it can improve the laceration, and this is important obviously for us. Okay. Just clear it from air. Okay. You hold it like that. Okay, so now I have both systems here. The catheter is, I can go to the side view, can maybe do the laceration. Do you have any questions for us in the meantime?
We're watching you carefully now for this
Okay.
laceration.
I'll maybe pull a bit the multi-purpose because it's a bit too deep for me. Yeah, that's good. We do not want the catheter to be on the leaflet, just a bit above it.
Ma?
Now I'm holding both catheters. So guys, what the next steps are like that. We're going to lacerate the leaflet.
Okay.
We'll see how she's doing afterwards. She's already shaky with the hemodynamics. If she doesn't look very stable, do we have the 20 millimeter balloon?
Yes,
Let's prepare it already. מאיפה?
Danny, why are you preferring to do the
20?
before you place the valve? You don't know what's the gradient now, so why would you do it?
True. It's especially when she's 89, right? So we do not want to do extra steps in. We don't want to cause any injury. The only issue is that I feel that we will have some paravalvular leakage that I want to prevent. But my gut feeling is that it's probably best not to do it and to see the gradients, but we'll be prepared to do it between.
Because if the gradient is not that high, you can settle on a gradient of 10.
True.
For 89 years old, you can accept a pretty.
Even
to be
15,
honest,
right?
I'd be happy with a mean of 20 something also. It's quite okay. We try to palliate an old lady here without having a big adverse event. That's our aim. But we'll be prepared on the back table for anything that we like to do. And until they prepare the balloon, do you have any questions for us about the steps, about the position of the catheters?
So, Danny, the height of the valve leaflet is about what, 14 millimeters or so?
Correct. Magnet 20, yes.
Yeah, about 14. How much do you think you're lacerating from of the 14?
I think that I'm about a third from the bottom of the valve.
Okay.
That's what.
Two-thirds of.
Yes, I think that since the piggyback crossed through the leaflet, we can look at the traversal point. Just a second, which means right here. It's about a third from the bottom. That's what. We want to be less than 50% in height. We did several bench testing to suggest what will create a larger Basilica gap, which means we need a lot more oversizing, be more at the base of the leaflet, be more at the center. These are the characteristics that increase the size of the Basilica hole. Okay, so Ami, you are about to be ready? Okay, so you can come here.
Okay.
So the valve is ready on the table. I'm holding both catheters and both wires or piggyback. At the right time, Moni will inject through the yellow, will inject the contrast, the dextrose, sorry, and you'll push on the yellow button. Okay? So I'll pull a bit the AL just to bring it to the inner curve. Don't like the multi-purpose is a bit too deep for me, so just a second, I'll pull it a bit higher. Okay, you're ready?
You're ready.
Just a second, it's not holding it well. So we'll do inject, you're injecting, and then I'll do Cine.
Okay. So I'm starting injecting now.
Okay, inject.
Okay.
Cine. Okay, on.
On.
Okay, it pulled the pigtail out, unfortunately. It's not easy to prevent that situation.
Okay, but she's stable.
Fortunately, she's stable.
Usually those patients are stable, that's correct.
Maybe on the wire.
Actually, hard.
ACT שלנו טוב?
Now, the first thing I do is to free the Basilica loop, which I did it right now.
כמה ACT?
The next thing would be to remove the AL out.
מתי האחרון?
Well, she is reasonably stable. Let's change the AL. Maybe you can look at the echo now and try to see the Basilica tear on the left cusp, or maybe exchange and back with the pigtail.
She has more aortic incompetence compared with before. We'll have a short axis view in a second.
Well, it's interesting that she looks a bit regular one. She looks a bit better in hemodynamics after we did the Basilica. It's not that sometimes it can improve aortic stenosis by doing that, by tearing a leaflet, but in the majority of these cases, they are less stable.
Okay, here on
so do you usually
don't see more aortic incompetent, but I think I can see the tear
אפשר
on
להראות
the
להם את
left
האקו?
coronary cusp.
פיקטל.
פיקטל מיד תקבל.
So do you usually see increase of the AR after Basilica procedure?
What do you say?
Do you usually see increase of aortic regurgitation after Basilica procedure?
Yeah. We all commonly see more AR. In many of these cases, fortunately, it's not that we have hemodynamic instability, but AR increase is common to see. Let's have AL diagnostic here and the pigtail there.
Okay. So this is a
Let's
pigtail.
remove this one.
Okay, we
So
can see
on the T view, I think some 2 o'clock the direction there is some redundant portion of the looks like a Basilica.
David, do you want to
show?
Yes, we can see the short axis view.
Yeah, show the axis view, and the 2 o'clock there is some redundant part.
About 2 o'clock, we can see the tear of the left coronary cusp. You see the color crossing the left coronary cusp. Is no doubt that the tear was successful.
Yeah, definitely. Yeah.
You can see here the color very nice.
2 o'clock.
פיקטל בפנים.
good.
אלואן.
רגע, wire.
a pigtail? Okay. Okay, the pigtail is waiting here, not for positioning for the TAVR, but in order to see quickly if there is coronary obstruction or something like that. Let's
אלואן
connect
יש לך
to...
פה.
Okay.
יש לי wire?
Just a second, I'll do it. Let's connect to this one, to the pigtail with the injector. small puff. Puff בבקשה. Okay, let's have a towel here.
אוקיי, תעבור רגע. מגבת בבקשה. מגבת גדולה.
דני,
גדולה.
יש לנו יכולת להחליף
גדולה.
ווייר עכשיו, ספארי?
מה אתה אומר?
אפשר להחליף ווייר ספארי? אתה לא בפנים, נכון? אז בוא נחליף.
זהו, בבקשה. אני צריך לחצות, אז...
כן,
So bring me a straight
ספארי
wire.
חדשה.
This is the
ספארי
picture.
חדש.
No, we need AL1 here.
כן, זה L1. שמת אותה.
Okay, so let me take this one out.
AL1.
So we will have the pleasure of crossing that small aortic valve 3 times. It's a good practice.
חכה שנייה. שנייה.
They want
אני
clean towel.
אסדר את זה תכף. כן, שנייה.
How much is the ACT, by the way?
קח את זה.
How much you want to keep it?
We want it to be above around 300.
מה? כן. כי אם היה עכשיו. יש אלכוהול פה?
בסדר.
תן לי אלכוהול.
L2.
בסדר.
That's AL2. Okay. Let's have a straight wire back.
זה על הרצפה.
אנחנו סטרייט פה?
זה מה שאתה מחזיק? מה זה?
זה סטרייט. כן. בבקשה.
מה זה? תביא לי חדש. תודה.
And in this case, you're trying to do the inline sheet.
When we do what?
Which sheet are you going to use? An inline sheet? Which sheet do you use
Yes,
now?
yes. I think that an inline, although here it's such a tortuous anatomy.
No, and sometimes the valve can be...
זה זווית אחרת?
always get checked, but
We may need an back to the AL1. This is the one that crossed before.
זה תקוע. זה הייתה קצת תקועה. המיטה קצת תקועה.
Call Yossi, that will help you with the bed.
יוסי, can you help us with the bed?
Good.
מיטה,
Yes.
מיטה.
Okay, good.
Okay. Be very careful with.
Okay.
We are after the valve deployment.
Safari
We
or
did.
לחצים?
Let's put a Safari and then exchange it to a pigtail. So we are after the deployment of the valve. We aimed for a slightly lower position than we conventionally like in small surgical valves.
So Danny, we don't have a lot of time, so maybe you can summarize what we have so far and see whether we can conclude within a couple minutes.
Yeah, absolutely. So we have done a left cast Basilica. It was actually straightforward, the Basilica step, but the steps around the Basilica are not so easy with her very tortuous anatomy. Now we have implanted, you can see it over here.
Nice.
Briefly take you through it. The Evolute 26, it's a lot of oversizing in order to prevent the paravalvular leakage as much as we can, not only the stenosis and the intra. It's about 4 to 6 millimeter in depth. And I'll show you that live. Just a second. It's maybe closer to 4 than to 6. And maybe David can take you through the echo. David, maybe you can describe the echo in the meantime.
Okay, we can see just a second. I want to. There is some quite significant aortic incompetence.
We will do. Yeah, let's take it out and bring the Atlas 20 balloon. We aim to do post-dilatation with a 20 balloon here in order to reduce the ppm and to reduce the paravalvular leakage. Obviously, there is no coronary obstruction. She does not behave like coronary obstruction, which is a very nasty complication that can happen in these cases. We have the Atlas.
Yes. Wait a second.
Okay. So we chose an Atlas 20 balloon, which is good for her LVOT size. I did not want to bring a larger balloon, non-compliant balloon, to that area. And it's a relatively short balloon, as you can see. We do not want to work too much on the LVOT side of it.
You want to fracture or just?
Yeah, we'll aim to do.
You want to fracture it?
A significant dilatation here. I'm not sure if a 20 balloon inside the 21 Magna would be able to fracture, but we will go to high pressure inflation here.
Sure.
So it would be this one, and then you. So first what we do, we will inflate the balloon with a syringe, with a large syringe, and then we will switch to the stopcock, and we will go to 20 atmospheres. Yeah, you can go here. So, and we do not go up, obviously, without seeing that the rapid pacing works well. So, who's on the pacemaker? We'll do 180 when we call it. Output all the way up. Okay, 180. Okay. Go. Go. Shall it stop go? Go. Go quickly. Quickly, תרד. Okay.
Stop
We'll take
pacing.
it out. Stop pacing, please. Stop pacing. She may need some resuscitation. Stop pacing.
Stop pacing.
Okay.
Good.
That was a long run, as we commonly need to do in ring fracture cases. Fortunately, she regained blood pressure. Okay.
Okay.
Do you see the hemodynamics as well, or only the screen?
Only the screen, no hemodynamics.
Okay, we went to 20 atmospheres. I think in this old lady to go to high 20s is too much. Let's see the paravalvular again. Let's change it to a pictal here. Okay, the next step is to check the pressure there and to do the aortogram. And we're probably done afterwards.
Danny, I missed. What was the gradient?
We didn't check it in the echo yet, but we will see it soon. We have done the BVF, the post-dilatation, because of the residual leakage that she had. Not a lot. As you can see, the diastolic blood pressure is a bit higher than half of the systolic, which is a good sign that the PVL is not of significant hemodynamic importance, at least now. We'll have two pictals here in a second. Okay, let's check pressure and pressure.
Now we can see the hemodynamics. Oh, can we see the hemodynamics? Thank you.
So we did like a borderline situation between BVF and
high
ring
pressure
fracture because of her background. So just a second, I need syringes to wash it and to do 2 zeros here.
Okay, looks
But you
good.
did fracture the magna, right?
Well, we went to 20 atmospheres with I did not expect it to fracture with a 20. And 22, and you see the severe MAC there. There are several specules that are coming inside the LVOT. I think it's too much for her.
Okay, Danny, did you use a true balloon?
2 zeros, please. Yes,
Yeah.
we used an Atlas balloon.
Atlas balloon.
Unfortunately, true balloons are not in use in Israel. We'll try to bring them in.
Atlas balloon, yeah.
2 zeros, please.
It's a very non-compliant balloon.
Yeah.
שני אפסים, בבקשה. There are several limitations of each of these balloons in BVF, and we had some balloon ruptures, and these could be not fun. You can say that in general, Basilica is much more complex to do than BVF, than ring fracture, but technically. But the risks of BVF seems to me at least much higher than Basilica. And you've seen I didn't hear the presentation of Ron, but I'm sure that he outlined the results on the clinical outcomes. And in general, we're very happy with Basilica cases. Unfortunately, it didn't really disseminate to many centers because the technique really has a learning curve, and it's not very common to do to have cases at risk for coronary obstruction. We are referring centers for that. This is why we get many of these. So fortunately, there is no gradient at all.
Yeah, good, excellent.
The AR index is not perfect, but we will accept it.
Yes.
We will surely accept it. Let's have a pullback.
So Danny, so thank you so much for an excellent case, and really we were able to see all the highlights and all the sort of technical pearls session.
Great.
So thank you so much. Because of time,
It's such a pleasure broadcasting the session, and be happy to see you live at some point.
You made the Basilica looks easy, so that's good. And
yeah, great. We learned lots of things from you. Great, wonderful.
Thank you everyone for participating, and we will conclude. And thank you again for all your staff and faculty at this session.
Okay.
Thank you so much.
Thank you. Great. Bye-bye. Great. Wonderful.
So I was asked to talk about the International Basilica and stent chimney registry results. These are my disclosures. So thank you again for the invitation and for the opportunity to present you the results from the registries of snorkeling and Basilica. The background, the TAVR causes coronary artery obstruction in about 0.7% of the cases with 40 to 50% mortality. It's a very devastating complication of TAVR. So we have two options. One is snorkel and stenting, which is also called chimney. And that's actually been used as a default procedure to prevent coronary obstruction. And Basilica, which we just showed the demonstration, is a novel technique to lacerate the aortic leaflets to prevent TAVR-related coronary artery obstruction. It's a little bit more complex, but it doesn't leave anything behind, which is a big plus. However, with both of those systems, there is not a lot of data that has been collected systematically. And given the low prevalence of the situation, but high mortality, we really have to ask ourselves who should undergo protection strategy and what should be the preferred method to protect those coronary arteries during TAVR. And this is an evolving situation and evolving field. What we can, or what we do know that, again, the incidence is maybe increasing when you have stented with externally mounted leaflets.
surgical valve in stentless, it's about 3.7, and in stented with internally mounted leaflets, it's probably the lowest rate of obstruction. So this is usually what we see post-procedure, and that's something that could be devastating. And there are some anatomic risk factors for coronary obstruction. Primarily, we are looking on the low coronary height and narrow sinus of Valsalva diameters. It's very important to know whether you have a shallow sinuses or not. And there is a CT analysis that gives you also the virtual valve to coronary distance, virtual valve to STJ distance, and leaflet height relatively to the coronary ostium. I don't think you can do any of these without CT, and it's very important to incorporate it into the planning. Now, as I mentioned, the two methods that are available right now is snorkel and stenting plus TAVR or Basilica plus TAVR. Obviously, you still have the option to do surgery. And why this is important, because if you have coronary obstruction, you're going to end probably with close to 50% mortality at the time of the obstruction. So what about the snorkel stenting? The advantage that it's relatively easy to do, and we are familiar with all the wire and the stenting, and it is actually preventing therapeutic measure. It would help, it will work. But there are some limitations. The limitations are risk of stent compression and difficulty of impossible to transverse the pinned leaflets. Often it's performed emergently. We're not prepared for that. And need for lifelong DAPT and also turbulent blood flow. And again, forget about another coronary access that's not going to be able to be done once you did the snorkeling. When I looked at the data, I would refer to two papers that were published in the same issue of JACC Intervention. Both of them actually was detailing results for multi-center international registry and for another chimney registry. Just to remind everybody, there are basically 5 steps that you are doing for this chimney or stenting. The first one is identify the patient at risk, and then you put safety wire and a stent not deployed in this case, the LAD or the left main. Then you deploy the valve. Then you create the chimney if there is a coronary obstruction. If there is no coronary obstruction after deploying the valve, you can avoid to deploy the stent, but then you may find out that if you remove the wire, then the leaflet may obstruct the coronary arteries. But if you do the chimney, that's how it looks in step 5, the final results. Again, if you just compare between doing the stents versus wires, and this is for protection, you can see that the stenting is going to be much safer in terms of protection. And you can see this is in the dotted blue versus the red line that will show you the coronary protection with only wire use. So I think that if you think that it's not going to be enough, then put the stent in. What about the long-term outcome? Again, we don't have a lot of data. These are relatively small series, but Tullio Palmerini was describing this in this paper in JACC Intervention, that overall the results were pretty good. He was comparing with stents and with wire. Wire is basically just protecting you. Should you need to add a stent, you can always add a stent. But you can see here that overall, with the stents, numerically, the outcome was a little bit better, and but nothing major statistically significant. And again, on the other registry, which was 60 patients, you see the patient's baseline characteristics and the procedural assessment. And one thing that is important, that if you look at the totality of the data for all-cause death in TAVR with chimney, you can see here that if you have no coronary protection in those patients, you're going to see much more mortality compared to those that you perform the coronary protection. So it's very important to not believe that you can do it, but to indeed take some measures of coronary protection. These are the predictors of 30 days death and MI and cardiogenic shock. And the most important one with the odds ratio of 8.81 was the absence of coronary protection. So again, it just says how important it is to do those. If you don't do valve in valve, it's only 1.4. If it's a balloon expandable THV, it's 3.36. Again, we're talking about coronary height less than 10 millimeter and VTC less than 4 millimeter as predictors for mortality with TAVR. So to summarize the snorkeling situation, I would say that it's feasible. You can do it. It usually works. The acute procedure results are encouraging, especially when there is a risk factors of coronary artery obstruction. There is a low incidence of stent thrombosis and small excess of MIs that was reported. Patients undergoing a coronary protection with wires only have a substantial risk of delaying the coronary occlusion. So that is the risk that we are taking. We cannot tell for sure that the wire is going to be protective. And that's why you see higher mortality if you use wire versus stenting. And stenting across the coronary ostia in patients undergoing TAVR at high risk for coronary obstruction is associated with favorable 3 years survival rates. So maybe not for young patients, but for the elderly patients, it's definitely a feasible and reasonable approach. We do need to get some more long-term data and larger series to understand the long-term outcome of snorkeling with stent or chimney. With respect to the Basilica, again, the advantages that it's been systematically studied. It's a preventive measure. There is nothing left behind. There is no risk of compression impairing flow. Limitation, it takes multiple steps. It's sometimes technically challenging, and it requires some dedicated equipment, although everything is on the shelf. And I think overall, if you do enough of those, it's becoming more simpler. There is a COBRA registry that was done, not a lot of patients, comparing between the stenting and the snorkeling. Again, these were the CT analysis that was required for that. And they look at the outcome analysis by coronary obstruction and clinical outcome. So these are the CT prediction that was done between the two groups, snorkeling versus Basilica. You see that they were pretty much even in terms of the entry. And the outcome showed that with snorkeling, you have clinical signs of coronary obstruction in 10 out of the 10 patients versus 0 in the Basilica. Stent required in the snorkeling technique was 7 versus 0. Stent successfully relieved obstruction was 6 versus non-available because you don't need it in the Basilica. And CABG was required in 3 cases of the snorkeling, and survived to discharge was 8 versus 10. So if you look at this very, very small comparison between the two techniques, Basilica is a winner. And again, if you can do Basilica, it definitely should be the default therapy because it does not leave anything behind. And any of those complications that you see here, you're not going to see that. Now, what the data about the Basilica? So first, there was a Basilica IDE under FDA, 30 patients, about 37 leaflet that has been lacerated. Overall, the success rate was 93%. Survival was 100%. Successful first TAVR device implantation was also 100%. And freedom from coronary obstruction was in all patients. And freedom from emergency surgery also in all the patients. So very good result. It was presented by Dr. Khan and published in JACC Intervention in 2019. But these were only 30 patients. So we conducted the Basilica Metzger registry, which is much larger registry. It was a retrospective multi-center single-arm registry, included patients who had Basilica to prevent coronary artery obstruction. We excluded patients that were in the Basilica IDE trial. So this is all after the IDE. It's multi-center. And we look at the VARC2 definitions that were used and to adjudicate the events. Altogether, there were about 214 patients from 25 centers who had a risk of coronary artery obstruction during the TAVR. And at 30 days, there was data on 240 patients, which basically, to summarize the result, ended with 2.8% mortality, 2.8% of stroke. Of this, 0.5% was only disabling stroke. So this is the patient characteristic. The mean age was 74.9. The risk score was primarily high-risk patients, although we had also intermediate and very few low risk. And you can see here the aortic valve was done in native in 27.2% and bioprosthetic in 72.8%. So this is not only valve in valve, this is also for de novo. And some of the patient had prior stroke and prior cabbage. These are the procedure type, again, using both valves. Sapien 3 was using in 60.1%, Evolut R Pro was in almost 40%, and the nominal valve size was about 23.5%. Most of those were transfemoral cases, and the target cusp was left in most of them, almost 70%, right solo only 9.8%, and two valves was done in about 21.5%. The sentinel cerebral protection, which was recommended, was used only in half of the patients. So these are the procedural results. Successful transversal of the leaflet was accomplished in 94.9% of the cases, successful laceration in 94.4% of the cases, no culprit coronary obstruction in 95.3%, procedural survival 100%, no emergency surgery or re-intervention in 93%, and procedural success overall 86.9%. These are the results at 30 days. So there was 2.8 mortality, not related to coronary obstruction, but patient sometimes dies at 30 days, especially the high-risk patient. Stroke was only 0.5% disabling stroke, and major vascular complication 3.8%, AKI 4.3%, and coronary obstruction in a non-culprit, including the non-culprit, was 5.7%, and re-intervention that was required was 1.4%. Again, by VARC, it's 82.8%. Secondary endpoints are shown here. 1 year survival was available in 124 patients, and it's 83.9%. So overall, relatively very good results. And maybe one thing about endocarditis, 1.4%. So when we compare solo versus Doppio, so one TAVR versus both leaflets, you can see here that the procedural success with solo Basilica is a little bit better. The VARC2 safety is a little bit better, but not statistically significant. And overall, the stroke rate was doubled in the double Basilica versus the solo Basilica, although there was no disabling stroke in the double Basilica. And if you look about bioprosthetic versus native, again, 155 were bioprosthetic versus 58 just de novo or native vessels. The procedural success was slightly numerically better in the native, but again, no differences in VARC, mortality, all stroke, and disabling stroke. But overall, very good result. What about cerebral embolic protection device? If you use the cerebral protection devices, the all stroke was 1%. If you did not use it, it was 4.5%. Again, we recommend to do this procedure overall with embolic protection device because all the manipulation on the leaflet can cause some embolization. Limitation of this registry, it's retrospective. This is a site-reported data. Coronary obstruction risk not determined by a core laboratory, and the comparisons are not matched groups. So in conclusion, this registry is the largest one that conducted for Basilica, and it demonstrated that Basilica is safe, low rates of stroke and death. Basilica is feasible in the real world in centers with experience, with appropriate training, with high rates of success and low rates of coronary artery obstruction. This reassuring data should facilitate wider dissemination of the Basilica procedure at high volume centers. With regards to the snorkel chimney, I would say that this can be left as a last resort when Basilica cannot be performed. And definitely there is an unmet need for dedicated devices for leaflet TAVR that can simplify the Basilica approach and protect the coronary from obstruction during TAVR. And with that, I'd like to thank you for your attention. Hope to see you next time in person.
Hello, everybody, and thank you for the opportunity to give you the presentation on Basilica and Chimney, A to Z Technical Pearl. I'm Danny Dvir, Director of Intervention Cardiology in Shaare Zedek Medical Center in Israel. Here are my disclosures. And we know that coronary obstruction is a devastating complication of TAVR procedures associated with 50% early term mortality. We need to identify patients at risk for coronary obstruction. We need to prevent that complication at any cost. There are several techniques to prevent coronary obstruction in TAVR procedures. The most utilized one is the chimney technique or snorkel technique, in which we utilize a stent to prevent the dislocation of the leaflet during TAVR procedure that will cause the coronary obstruction. In chimney procedure, the method is of preventing coronary obstruction is by having, before the TAVR procedure, a wire and a stent waiting in the coronary tree, and then the TAVR is formed while the coronary protection is being held, and afterwards the stent is was waiting here. We see the coronary obstruction here. We pull the stent towards the area of interest, we deploy it, and the leaflet that caused the coronary obstruction is being pushed a bit, and there is flow to the coronary tree. You can see it like as a bifurcation procedure in which the left main is the side branch and the aorta is the main branch in some way. Well, in general, the guide that I'm utilizing usually in these procedures is for the left system a JL35, a short JL, and for the right I use a multi-purpose. And usually I utilize a stent that will go up towards the sinutubular junction and hopefully will not cross the left main bifurcation. You need a good post-dilatation, and usually I use an IVUS in order to understand that the expansion is working well. But in general, I think that we have now more modern tools to prevent coronary obstruction, and I will describe several of these techniques and tools. One of the issues with the chimney technique is the fact that also if you did not see coronary obstruction during the technique and you pulled out the stent, still there could be delayed coronary obstruction caused by that leaflet that is being very close to the coronary ostium. And the durability of the chimney or the snorkel technique is questionable. There are cases in which we saw issues in follow-up. Here is an example of delayed coronary obstruction of the right coronary artery and restenosis in the ostial left main after utilizing the chimney technique. Also, there are technical issues related to the technique in which when you want to not deploy the stent, you want to take it out of the coronary tree when, for instance, there is no coronary obstruction, but the stent is jailed and it's very complex to remove it. Here are two examples of stents that were like dislodged from their balloons and needed techniques to remove them afterwards. So basically, the origin of the coronary obstruction in these situations is the leaflet, and we need a better method to prevent coronary obstruction optimally by modifying the failed valve leaflet. We need to work on the failed valve leaflet. This is what led to the Basilica concept, in which we understand that a single leaflet tear, if we tear that leaflet, then afterwards, when we do the TAVR procedure, there could be flow through that gap between the partition between the two sides of the leaflet. So our aim is to slice a leaflet that may cause coronary obstruction. Now the question is, how do we slice a leaflet using transcatheter tools? We understand that after we have a sliced leaflet and we deploy a TAVR device inside it, then it separates well the two parts of the leaflet and there could be flow through it. Here is a short animation that was created by the NIH related to the Basilica procedure. Basically, we want to traverse the leaflet with an electrified wire. I'll describe it in short. And afterwards, we want to electrify again the wire while pulling it from both sides. So two steps in which we electrify the wire, first to traverse the leaflet and then to lacerate it. Basically, the procedure steps were described in several papers, and here is one of them. Basically, after we do the access for the procedure, we position a snare in the LVOT, and we have a multi-purpose guide that is holding that snare. In step number 3, we position a catheter behind the leaflet of interest. There's a mitral flow Basilica procedure. There is a telescope of devices that will stand behind the leaflet. It's a guide. It could be a long IM diagnostic catheter, a piggyback microcatheter, and through it an Estato X S20. That wire is electrified, is being pushed towards the leaflet. Then that wire is being snared and we have a loop through that leaflet. And later on, we electrify the wire again and pull both catheters up. And after cutting the leaflet, then we conventionally do a TAVR procedure and evaluate again if there is or there is not coronary obstruction. So this is in short how to do Basilica, but I urge you to read about it and all the limitations and issues related to each of these steps. Obviously, we need to understand when we cut a single leaflet, how to orient towards that leaflet in the cath lab. Basically, we can view each of these leaflets in the front view and the side view. You can read about it in our different publications. And these different views are projected along the perpendicularity graph of the aortic valve from ariocaudal to iliocranial. The left cusp side view is in iliocranial, left cusp front view is in ariocaudal. Another consideration is the eccentricity of the coronary ostium. When we cut a leaflet, we need to understand how the coronary ostium is oriented towards that leaflet, whether it is oriented towards the center of the leaflet or is it very eccentric. Here's an example of Basilica from the first Basilica procedure that was performed in 2017 in Seattle. Since then, myself, I did hundreds of these, and there are a total of many hundreds Basilica procedures to date performed worldwide. And the Basilica was also performed for failed THV devices. Here is an example for Basilica for failed core valve device, a double leaflet Basilica for the left cusp and for the right cusp, and later on implanting a TAVI inside that failed core valve that it was at risk for coronary obstruction for both coronaries. And you can see that there is no coronary obstruction. And more Basilica procedures are performed for failed TAVR devices coming for valve-in-valve. We did see in the past adverse events related to Basilica procedures. Me and colleagues, some of them are related to the traversal. Where is that wire when it traverses? Sometimes it may not traverse through the leaflet, may traverse para-ring, or may traverse through the aortic mitral continuity after it goes through the aortic valve. And you can read about it in our different publications. There are many other potential adverse events of Basilica procedures, as you can see here and here. So I do urge you to, if you want to try that technique, to get proctored or learn the steps well and the potential limitations and the adverse events that can happen. Here is an example of a piece of a MitraFlow leaflet that we captured in a sentinel, the sentinel in that procedure. Or it could be that also parts of the leaflet could tear, and conventionally I use neuroprotection devices during these procedures. Here is a devastating complication of a Basilica procedure of one of my colleagues that caused the aortic dissection. So it's not without potential adverse events, as you can understand. Coronary obstruction can also happen with Basilica. This is an example. It's very rare, maybe less than 5% of cases having Basilica would have coronary obstruction, but it can still happen, and we need to be able to go back to the coronary tree. I'll finish with describing a dedicated transcatheter leaflet splitting device tool that is called Shortcut of Picardia, that is able to perform the Basilica steps much more easily than the steps that you've seen before. It's a dedicated device that is being now evaluated in compassionate cases. The device is able to stand behind the leaflet that we want to tear. As you can see, it is able to land towards the leaflet that we want to tear. And afterwards, there is no electricity involved in this procedure. There is a micro knife, a splitting element that is activated. It pierces the leaflet, and afterwards, the leaflet is being torn by pulling the device. You retract the device, and then the leaflet is torn. So there is no electricity involved, and the steps are much more easy to follow for new centers that try to do Basilica procedures. The device was evaluated extensively. I did a lot of bench testing and animal studies, and I utilized it in 5 compassionate cases. As you can see, cases at risk for coronary obstruction. The 3 last cases were a double risk for coronary obstruction, right and left. So a total of 8 leaflets at risk for coronary obstruction And as you can see, 5 patients, 8 leaflets, all procedures were successfully completed without any complications and with good coronary flow, no post-operative adverse events whatsoever. So I'd like to summarize that coronary obstruction is a life-threatening complication of TAVR procedures. And it seems that we lack tools to prevent coronary obstruction. Chimney or the snorkel technique is the historical method to prevent coronary obstruction. It is very easy to use, although there are limitations to that technique. Basilica splits the aortic cusps that may otherwise cause coronary obstruction, and it was utilized in many hundreds of procedures to date. And it could potentially be the preferred therapy in patients at risk for isolated single vessel obstruction, but the optimal therapy for patients at risk for double obstruction and in use centers that do not know how to use Basilica may utilize novel devices like the shortcut that I described and now is being tested, and it may improve procedural safety and efficacy. So thank you very much for your attention and have a nice day. Thank you.